And so to try to make a little summary for myself so that each time I do a case, I follow a specific protocol, I made this chart. And the way it works is after you have your initial data collection, then you're going to do a case workup. Case workup means mounted models or digital models, doing these risk assessments, evaluating vertical dimension, evaluating lip support, transition line. And then once you do the case workup, then only then can you make a proper diagnosis. You can't just see the patient, not take any records, and make a diagnosis, because the diagnosis many times will lead to what the proper treatment plan is. So once you have a diagnosis, then you can sit down, and like I do at the end of the day, I have my mounted models, I have my photos on the computer, I have my x-rays on another computer, I have the perio chart printed out, I have my periapical and bite wing, I have everything that I've collected to do the case workup, so that I could now start to think what are the possible treatment plans for this patient. And like I said, I'd like to give them a plan to save their teeth if their teeth are savable, and then we go through options that are with taking their teeth out, snap-ons, screw retained hybrids, locator fixed, and put that in a nice sheet that you can give to the patient so that you could then sit down with them at the next appointment, go through that, and if it's a little bit overwhelming, they can go home, they can talk it over with their loved ones or their spouse or whatever, and really make time to make a good decision. It's not infrequent that I'll bring the patient to the treatment plan presentation, and sometimes they say, this is what I want, and we just move forward. Other times they'll go home and we'll either have another phone consultation, or they'll come back for a final live consultation just to answer some more questions. And then once you have presented the treatment plan options and the patient chooses what direction, now you can do your surgical and prosthodontic planning. You can plan the positions of the implants, you can plan the prosthetic, you can plan the surgical guides, and in that way you pretty much virtually completed the procedure before the surgery. There's no surprises. You go to your surgical execution. I go to the surgeries on an immediate load type of case, and I'm going to provisionalize, pick up cylinders or pick up locator abutments. And then after a 3-month healing period, we go to the definitive prosthesis, and then the maintenance is always just as important, as all the rest. So that'd be a good picture to take a good chart to take a picture of to make sure that you follow those specific steps. And I named that meticulous interdisciplinary collaboration. I don't know why, but it sounded good. Okay, and so this little, are we at noon yet?
15 minutes.
15 minutes, okay. Is BJ gonna?
He's gonna come in and lead the tour.
Okay, is he coming at noon?
He's coming in a few minutes.
Okay.
Are we almost finished?
I gotta see if I. Oh, here. Well, no, I think we could go through this real quick before it gets to the next. Uh-oh. Okay, so this part of the lecture is own your arches, meaning take accountability, care about the patient, do the things that it does to work up the case properly and have a good outcome. And so for me, the only way I could come up with a good outcome is by having a multidisciplinary patient-centered approach, meaning make each individual patient a customized plan, and I like to work with the other specialists. Like I said, once I said this, I had a dentist come back and tell me that they do everything and thought I was criticizing them. I think there are dentists that can do it all in terms of surgery, but for me, I'm not talented enough to do that. I want the surgeon to control part of it, and it makes me feel more comfortable from a medical legal standpoint. I don't feel like I'm out on an island. And I also like the camaraderie that I develop with these surgeons, because I refer them patients. They know what I do good. They refer me patients, so it just all works together. But if you start to skip steps and take shortcuts, then that predictable outcome will many times fall apart, and the case will be misery for you and misery for the patient. So what does it take to own your arches? First thing is, we don't want to have a one-size-fits-all philosophy. Like I said with some of the corporate centers, that everybody that comes in is going to get a full arch hybrid of some kind or a locator fixed of some kind. I have some patients who have gone to these centers and they didn't like the experience. They weren't presented any other options. They felt like it was it's a hard sell. So keep an open mind when you evaluate a patient. Don't make any treatment decisions till you've collected all the information. The next thing I see that causes problems where you're not owning your arches is inadequate case workup, skipping all these steps that I've showed you on a couple of these cases. And the cases we'll see this afternoon, there's some other little twists that you'll see in terms of what I think you need to do to have a successful outcome. Another thing is poor record taking. So I live 5 minutes from here, so I'm dropping off cases at the end of the day. I know all these guys good. I'm walking through the lab. They don't care if I look at cases. And when I look at impressions that are totally inadequate, I look at models that have bubbles or defects. When you're doing these cases, you can't have a model that has a defect. You have to have if you're going to be fabricating a guide off of a model, it has to be perfect, because if the guide doesn't fit, if the guide fits differently on the teeth than is in the model, then that guide is completely worthless. You're going to be putting implants in positions that they shouldn't go. I also find that lab technicians, when you give them beautiful work, beautiful models that are, the stone is smooth and polished, they call you and they say, this is beautiful, and they want to do the same for you. The better you give them, the better they're going to give you. So it's a good strategy to really get a good service from the lab. Next is over-delegation, and I am seeing this more and more in the digital world. Things such as, like I showed in another case, if the assistant doesn't know centric relation and centric occlusion, and if they're just scanning a patient or they're squirting bite registration and having the patient bite and that jaw comes forward and CR is not equal to CO, you're adding inaccuracies into the case that will cost you time and money down the road. Here's an example of that. Here's a patient that here's his centric occlusion position. And when I guide him into centric relation, he's end to end. So just think about how big of a discrepancy, how far he moves from CR to CO.
What's your trick to getting patients into CR?
So some people, and so I'm not a panky guy that everybody has to be in centric relation. I don't equilibrate patients that don't have symptoms, because different people can adapt to things differently. Some patients, like you say relax your jaw, and they drop back and go, and you could repeat it over and over again. If a patient's like that, I don't do anything special. But what I do a lot is I use a leaf gauge. Okay, so a leaf gauge, I place the leaf gauge with extra leaves. I have the patient close, I have them slide forward and back, and have them hold it. And I ask them, are any of your teeth touching? And they say no. So I take a few leaves away, I put the leaf gauge in, forward and back. Any teeth touching? No. So you keep taking away leaves till you get that first contact that will cause that hit and slide. And then I add another leaf to it. So this time when they close, they're not contacting, but they're as close as they could be without having that interference. So then I squirt my bite registration in the mouth. And you got to go really quick because those bite registrations set quick. put my leaf gauge in, have them slide forward, back, and just have them hold that. And that's how I mount the centric relation. I've used a Lucia jig, the little plastic things that they close on just to relax their jaw, and then you can leave that in to take the bite registration. But everybody has their own way. But I use a leaf gauge a lot because most of these really complex cases, they have shifted and drifted teeth. CR and CRO aren't usually the same. And for whenever you're going to restore an entire arch or both arches, you have to restore in centric relation. And so here's that patient after we did an upper full arch type of case. And the last thing is abdicating control to the lab. So you don't want the lab to make the diagnosis. You don't want the lab to have to tell you what to do next. You don't want your lab tech to be coming in and taking the impressions for you or taking your bite registration, because from a medical legal standpoint, that's not legal. So this is all about owning your lab, getting the education to do these things the right way, so you know how to write your lab scripts and not just call your lab and say, okay, what's my next step? This Zest, what's the course in Vegas?
Zest Mastership.
The Zest Mastership. That would be
You
a.
don't have to go to Vegas. You can come right here to Cleveland.
Okay, but Vegas is fun.
Vegas is fun.
Yeah, at those courses, there's multiple instructors. There's people that have all different aspects of. Many of them would do things differently than I. Some the same. But the more education you get, the more knowledge you have, the more you can know what to do and the order to do it. I come to the lab sometimes and I just watch the scanners or I watch the designers, because when you know what they do on the computer, it helps you to know what to give them. It's very helpful to understand all aspects of treatment. Almost done with this spot. So you should be determining vertical dimension. You should be determining the prosthetic design. You should be determining what occlusal scheme you have.